Hello, we're here to discuss the topic of delirium. I'm Rebecca.
I'm Steve.
And we're part of the Older Persons Mental Health Liaison team. Our team consists of 2 full-time staff and 3 part-time staff. We work 7 days a week. Core hours are 8 till 4. And we cover all of the wards in Gloucester Royal and Cheltenham General Hospital. And we see people over the age of 65, or if they have a diagnosis of dementia, we see them when they're a lot younger.
So our subject today, as Bex has just said, is delirium, which is an interesting subject really, because when we were discussing this earlier, we were thinking it's not really looked upon as a mental health disorder. It's, we often get referrals in the team for people with delirium who present as, quite confused, and it can appear to be a mental health issue. But the underlying cause is that of a physical nature. So today we are aiming to look at what those causes can be and what people are most at risk of catching delirium and the different types of delirium. So that's where we thought we'd start, isn't it?
Yeah, so the main causes of delirium is, the easiest way to look at it is the acronym of Pinch Me.
Yep.
So the P in Pinch Me is pain.
The I is infection.
The N is nutrition. So are they eating, drinking? Have they suddenly stopped, which could cause it as well?
Going on to the C, constipation. Constipation can be, quite a frequent cause of confusion with rising levels of toxicity in the body, which go on to cause the confusion. And it's one of the things that's often missed, isn't it?
Yeah.
Really. So that's an important one to be checked.
And the medication can cause constipation as well, can't it?
Yeah.
So it's looking at that as well.
Frequent painkillers, things to look out for there.
And the H is hydration. So are they drinking?
Yeah, staying hydrated. So moving on from the pinch to the me, you've got medication. So medication can be a cause of confusion, as with opiates, with the link to constipation, but quite often any change in medication, if people suddenly present as confused, it's thinking, have they suddenly been stopped from anything? So is that a cause, or is anything new just been started? So it's really important to be checking those areas as well. And then coming on to the last one in Pinch Me, it is the
environment. So obviously moving from a home environment to hospital, that is that can cause a delirium. But also what we see a lot is moving from ward to ward. Moving within the hospital can cause someone to become delirious. And then more often than not, but it can happen that patients have gone from home to a community hospital to a care home and then back to hospital, and all those can be very disorientating for the person.
Yeah, and it's not just the change in environment as well, is it? Hospital wards are really sort of busy, noisy places.
Yeah.
All of which can be quite sort of big trigger issues for people, and sleep can be disturbed, and it's all of those environmental factors that need to be taken into account as well.
Yes, yeah.
Yeah, so
in a few stats is that I think it's about 1 in 10 people who come into hospital could develop delirium, and that increases to 1 in 3 if you're over the age of 70. So it's very, very common. And I think that's one of the most important things from this training, is to think delirium. Could this be a delirium?
Yeah.
Make people more aware.
Yeah. So moving on from that, we were also going to look at the sort of different types of delirium.
Yes.
And there are, I always thought there was 2 types, but I've learnt myself doing this that there's actually 3. These are known as hyperactive delirium, hypoactive delirium, or a mixed delirium. So if we look at hyperactive delirium first, these are the ones which I think are probably most commonly spotted and picked up on, because these are people who are going to be difficult to miss. With hyperactive delirium, you find people can be really agitated, obviously presenting as confused. You're more likely to see people becoming more irritated, possibly aggressive, not just in tone, but sometimes leading to physical aggression.
Yeah, refusing care and treatment.
Yeah,
Hallucinations.
Yeah, invading, sort of invading or going into people's others' body space. So you might see people trying to leave the ward or going into other areas or other people's bed spaces. So leading to more confrontation, really. Yeah. And I think they are, generally speaking, the patients who need the most careful management in terms of maintaining their safety and the safety of others. So I think those are probably the sorts of delirium that are most often picked up on, aren't they? Or referred to us.
We get the most referrals from, someone experiencing a hyperactive delirium.
Yeah. So that's the hyperactive delirium. And then we move on to the other sorts, the hypoactive.
Yeah, the hypo. So that's hypoactive delirium. So it's the opposite of a hyper. So it can mimic depression. So it's someone who potentially could be staying in bed all day, refusing food and fluid, refusing medication, sleeping a lot. And just we get referrals from yourselves for, say, someone they think there's low in mood or they've got a depression. But it's, you need to think about whether it's a hypoactive delirium.
And I think with hypoactive, that is the risk of those is they are the sort of people who can almost get forgotten because they're the quiet person sat in the corner, aren't they? They're not sort of in your face and needing constant sort of management. They're that, when you're on a really busy ward, which, let's face it, everyone is, and you've got that sort of one quiet person in the corner, that they are often the ones that can get overlooked. But it's important as well to check to see whether or not they've got a delirium, this hypoactive one, and are needing more thought to go into the management of that and thought about the causes of that.
So are they having something that's underlying that's not been treated? Which is causing the hypoactive delirium.
And it's often confused, like you said, with depression, isn't it? You think, well, there's that quiet person in the corner who's depressed, and that they are often, when they are picked up, come through to us as a depression, don't they?
They do.
Query low mood.
Yeah.
So that's where we see those.
Yeah. And then we've got the mixed delirium, which is, as you can probably assume, a mixture of the two. So it can go from hypo to hyper, and it can vary from day to day.
That was a new one to me, but do you think mixed delirium is what I've always thought of as a fluctuating delirium?
It can be, yeah.
Because I remember hearing when people are recovering from a delirium, because the recovery from a delirium is never straightforward. It's never that 1 minute they're in a delirium and then next minute that's gone, is it?
Yeah.
Or they've recovered. It can take weeks, can't it, to get back to a sort of stable baseline, months.
It does say that it can take 2 to 3 months for someone to return to their baseline. Or unfortunately, sometimes they don't return to their baseline. They get a new norm, which is normally when they've got an underlying cognitive impairment or something. But as you said about fluctuating, I think the difference between fluctuating delirium and a mixed delirium would be that the two extremes, rather than just a little bit up and down. There is extreme from one to the other.
And I think one thing that just came into my mind then was we've talked about the process of recovery and how that can take a long time, but also when you're looking into has someone got a delirium, it's the history of the way that delirium developed that's really important, because when people have got a mental health disorder, there's quite often a long history to that. You can look back over weeks and months, and you can suddenly get a history of someone's mood decreasing or their behaviours changing in some way. But I've found with most deliriums, when the onset of them can be really rapid.
Oh yeah, it can be within a day, a few hours. And I think that's the difference between delirium and dementia, because dementia is something, as you were saying,
long time.
It goes a period of time.
Yeah.
Whereas delirium is the sudden onset. And that's how we differentiate between the two.
Yeah, because we again, we'll often get referrals and we say that someone's developing a schizophrenia or a psychosis, which in itself is a very rare event in the sort of over 65 age range, isn't it?
Very rare.
But, delirium, much more common, certainly much more common in that age group. And if the confusion has started very quickly, that would all point in the direction of a delirium.
Yeah.
And I suppose then what's needed are blood tests for infection markers and to go
through the pinch me.
Go through the pinch me.
See if any of them are...
Yeah, to check all of that, isn't it? Is the way to go if people are presenting in that way.
Yeah.
So...
Should we talk about people more at risk of getting a delirium?
Yeah.
Yeah.
So let's do that.
Over the age of 65, you're definitely at a higher risk of developing delirium.
Yep. Anyone who's recently had surgery, coming out of surgery and anaesthetics, nasty things often can cause confusion when people are coming out the other side of that. So those are all people more at risk in any age. But again, looking at the older people who are the most at risk.
And the most common one for developing a post-op delirium is if they've fractured their hip or broken their hip.
Yeah.
I think that's just purely due to the length of time it takes for that to heal.
Yeah, and maybe they've got to be in surgery for a long time. I don't know. I suppose all of that contributes to it, doesn't it?
Yeah. Anyone with a diagnosis of dementia or cognitive impairment, higher risk.
Again, brain injury. All of those people more at risk of delirium.
Yeah. Sensory impairment, so if they need glasses or hearing aids. Excessive alcohol consumption. What
have we missed? Chest infections, urine infections.
Yeah. Very common in hospital
factors. Blood's been out of sync for any reason. We've seen someone this week with hyponatremia, so low sodium levels can contribute. Well, I suppose now is a good time for us to talk about the treatments of delirium.
Yes.
Just one of which is medication, but I think it's important to think that medication isn't the complete answer.
No. It's finding out the cause of the delirium.
Yeah.
So what's caused someone to have it. So it would be treating the infection or treating the constipation, so on and so forth.
That's what's going to actually start treating and relieving the symptoms, isn't it? Is to identify that underlying cause.
Yes, but what can help is the NICE guidelines is using a small dose of antipsychotic medication, haloperidol. Yeah. So that's 0.5 milligrams BD. They can have extra PRN, so another 2 doses PRN. So maximum 2 milligrams in 24 hours. And that will help with the symptoms associated with the dementia. So if someone is hallucinating, it could help with that. Or if they're paranoid about someone putting things into their food and drink, so they stop eating and drinking, it can help. But
I suppose with that, part of the reason why haloperidol is one of those drugs that is available in oral form and also IM, isn't it?
Yes.
So if need be, there's a choice in ways that can be administered. But then that's where I think thought is needed on capacity as well,
Yeah.
and whether or not the medications need to be considered to be given covertly
Yeah.
in the best interests
Yeah.
of someone. If that is, if I suppose it's when the risks are such that that intervention is really needed. So that's almost a whole new session, isn't it, when you start getting onto capacity and best interests? But I think it's important here to highlight that that's something which is needing consideration, isn't it,
Yes.
by the treating
Yeah.
teams.
And another thing that you need to consider is if a patient has a diagnosis of Parkinson's disease or Lewy body dementia, they cannot have haloperidol medication.
Yeah.
But if anyone needs advice on that, by all means, give us a call. And we've got a consultant psychiatrist in our team, so any medication queries, we can pass it by them as well and get back to you.
And I think other generally good advice when it comes to treating someone is to look at what else can be done. It's not just medication, like we were saying earlier. It's also about trying to manage the environment. I think trying to make sure the patient's in an environment which is, not near a really noisy desk with telephones ringing.
Yeah.
Trying to reduce those sort of other stimulations really, which could be difficult for someone when they're unwell to manage. And also really concentrating on hydration. We've mentioned that hydration is a big factor with delirium or dehydration, but it's really important when you've got an agitated patient to be giving them regular prompts and making sure that they are taking on board the basics and staying hydrated and looking after themselves. So it's important that that's not overlooked, isn't it?
Yeah, and that could be more beneficial than having medication as well.
So that's good. I'm trying to think what else would help. I think to try and avoid us moving them around the hospital as much as possible. It's always easier to say rather than do, but trying to keep any nursing staff that are allocated to that patient as stable as possible, because the therapeutic relationship's really important. So to try and have as much consistency of carers as possible is also something that I would recommend.
And also regularly orientating the patient to the ward, because they may wake up in the morning and not have a clue where they were.
Yeah.
So saying where they are, why they're here.
Yeah, yeah.
That might need to be done several times throughout the day, not just once.
Yeah, and I think reminiscence is a therapy that works for a lot of people. And I think sometimes if relatives also don't know how to handle this situation at all, it can be really alarming when they suddenly see their family member having suddenly become really confused. And I think reminiscence, if they can come in and, I don't know, go through some photos or anything which is familiar to them, which is going to make them feel safe and help, that helps bring people back to baseline, doesn't it? All of those sort of things.
And a good thing to get family to do when they come in is to fill out a "This is me" form.
Yeah,
because
really
then
good.
That can look at what the patient's likes, dislikes, interests, past jobs.
Yeah.
And then healthcare professionals know how to start a conversation with them.
Yeah.
And you said about reminiscing.
Yeah, it's good. It's good. So I was thinking we covered the main points we were looking at, weren't we? And in the next part, just to bring this to an end, because we know that we didn't want this to sort of take up too much of your time, we have been really lucky today in that we have managed to invite someone who's actually had a delirium, haven't we?
We have, yes.
And not many people who've had a delirium are able to recall what that was like and what they went through. So we would like to introduce you to someone who can help show us what that's a bit like through sort of evidence through experience.
Yes.
Isn't it?
Yeah. We will let her do her introductions.
We will. Hi, and so here we have Emily. And Emily, thank you for joining us today.
Not at all.
Emily is an expert by experience with delirium and also works within the mental health liaison team as a psychiatrist with us. So thanks for coming today. We really wanted your insight into what it is like, because you've actually had a delirium.
Yeah.
And you can remember what it was like.
Yeah, I can remember bits of it. Yeah.
So how long did it last? What was it like?
So it was a good few years ago now that I had it. And it was when I had tonsillitis.
Yeah.
So I had a real bad infection. And the bits I remember, so I remember feeling poorly in the morning, obviously.
Yeah.
Reading the doctors, sorting out getting some antibiotics and stuff. And then that afternoon, I was just really, really confused. I couldn't think properly. It felt like thinking was really, really hard work.
Yeah.
I was absolutely exhausted. And then I think the day afterward, I'd actually started hallucinating as well.
Wow. What were you hallucinating? What was that?
So I was, I was hallucinating. I could see little penguins coming through the wall. So I was lying on my sofa and I could see penguins coming through the wall. And I remember asking my husband why there were penguins in our front room.
Yeah. Wow. And how long did that go on for?
So I think I must have been confused it must have been a few days that I had it, because I ended up having to go into hospital for more treatment of the tonsillitis, because it was obviously bad.
Yeah.
But yeah, I think I'd been confused for a good few days, I think.
And did you end up on the national delirium pathway? Or how was this treated? Or was it just that the tonsillitis resolved?
I think it was, so I think you were talking about kind of your pinch me factors earlier.
Yeah.
So I think it was just the fact that those were managed. And looking back at it, I had quite a lot of them. So I was in pain because of the tonsillitis, and that was obviously my infection.
Yeah.
My tonsillitis was bad enough that I couldn't eat or drink properly. So I wasn't getting good nutrition, and I was dehydrated as well. And then when I did come into hospital, I had to have some steroids, and that can be another kind of one of your medication causes.
Definitely,
delirium as well. But when those were managed, then that's when I started to get a little bit better and was able to kind of think a bit clearer and realise where I was and not see penguins.
And that must have been a really nasty infection, because obviously you're not even someone who's in the high risk bracket, are you? You are, a young person. Clearly not in the over 65 bracket, but you still had a delirium.
Yeah, that's it. And it's, though we think about it more in the older adults, but it's absolutely anyone can get a delirium. You don't need to be an older adult or have a dementia or have a hip fracture, for example, to get a delirium. If you have enough of those pinch me factors, then that can cause a delirium in people.
It's good. And that's interesting for us as well, because obviously we work within the Older People Mental Health Liaison team. And, it's useful for me to hear that as well, to remind me that this is something that affects all ages. So, thank you very much for sharing that with us today and with any of our potential viewers. And I think that is the end of our podcast.